I am delighted to introduce Dr. Kathleen Carlson. She's a professor of epidemiology in a School of Public Health at our neighbors for the North, or HSUPS School of Public Health. Longtime friend of OSU epidemiology. We're delighted to have her back. She's also a core investigator in the Health Services Research Center of Excellence at the VA Hospital up in Portland. She's an OSU alum, got her undergrad degree in biology here, and then went to University of Minnesota for graduate training in environmental health and epidemiology. Dr. Carlson does research on the full spectrum of injuries, including epidemiology of both intentional and unintentional injuries. And then more health services research focused, she does work with therapies and rehab for traumatic brain injuries. Her current foci of research are gun violence, opioids, and other medical or medicine-related injuries. We often forget about poisonings when we think about injuries, but those are a big piece of it. TBIs and auditory injuries among active duty and veterans. So welcome, Dr. Carlson.
Thank you, Mara. Thank you. Thanks, everybody. And thank you for hosting me and inviting me down to my alma mater. There's pretty much no other place that makes me as happy as Corvallis and the OSU campus. So it's a delight to be here. Hi, everyone online. So I may get cut off at the end, or if you go at a quicker clip, I'm not sure how the timing will work out. I got interrupted a couple times on my practice run-throughs, but I'm going to do the best I can here. So just by way of introduction, I am a born and raised Oregonian, born in a small town called Bonita in Lane County, somewhere in between Eugene and Florence on the coast. And in Lane County, or my little hometown, this is my preschool, which was in the Grange, the local Grange. And this was about a mile from my road. This is Highway 126 to the coast, a mile from my home. And then what kind of defined us was logging, spotted owl, which caused some economic depression in our area. And then the Oregon Country Fair defined us, if you've ever heard of it. But we were, a mix of loggers, a mix of Oregon hippies, but also quite rural. And my family was firearm owners. We lived off the land a bit, raised animals, had guns for safety. My mom would carry a pistol if we were out and about in the Oregon woods, foraging or hiking or whatnot. So I have some experience from childhood in the kind of the culture of firearm ownership. And then, as Marat mentioned, I scooched on to Corvallis and got my undergraduate here. I was introduced to public health actually by my mentors here and was connected with Anne and Bill Rosignol, who used to be professors here, wonderful people who introduced me to all sorts of things, including injury epidemiology. And I really fell in love with injury and violence as kind of the underdog of public health. And then public health, of course, like the fighting underdog of medicine, health and medicine overall, too. So I really carry the torch for this discipline and trying to make a difference in rates of injury and violent injury in our population through the tools of public health. So I have, one rodent. I meant to put nice Benny Beaver here. That's who it was when I would go to school here. Moved from one rodent to the next rodent, started at the Minneapolis VA, ultimately got home to Portland, and this is the Portland VA, and then OHFU and our compound up there. So Oregonians, I'm riffing off of that bumper sticker that you often see driving around here, but this is just another nod to my upbringing with my grandma, who was out here, lived in Paloma, and was no stranger to self-protection. This is my brother in the 80s, picking a feather. My son learning from grandpa how to shoot a gun. And this is me trying to make up for lost time because I was never a big fan of the firearms. Although it could be because my parents put the fear of death in me if I were to go near those firearms that were not locked up securely. However, they say, like, statistics show that, or network analysis shows that about 98% 8% of us know or will know someone who is impacted by gun violence or fatal firearm injury. And I'm no exception to that. My grandma survived this, but she was the victim of a shooting spree in Clackamas back in the early 60s. There was actually a movie made about that ordeal. It was kind of a big deal. And this is my grandpa, Angus Moore, who died about 10 years ago from firearm suicide, World War II veteran. And after my grandma died, he ended his life too. So I can speak to, the culture of firearm ownership and the importance and the value around that and the independence that it can bring. And on the flip side, the devastation and the loss and the trauma actually of that scenario when it occurs. So what I wanted to share today was some of the epidemiology of firearm injury and gun violence, and then the public health approach. I think this is kind of like, my carrying the torch for injury prevention as a public health discipline. And how do we approach gun violence? It seems so helpless at times, when in fact we have all sorts of tools that haven't been applied to reduce this burden. And then I'll share some of what we're doing up at OHSU and PSU to build a gun violence prevention research center. This is a new effort. And then some of the projects, I just have 2 snippets of projects that I wanted to share with you that my hope is inform the science and practice here in our region and in Oregon, and then also feed into the science of firearm injury reduction nationally too. Okay, so for as long as I've been looking at injury and violence, injury is a leading cause of death for all ages up to 45. And this is unintentional injury in the blue here. And then intentional injury is suicide in the green, homicide in the orange. So a major player in terms of fatality across the lifespan, but especially in the younger years. But then the 4th leading cause, and this is behind COVID, this is for 2020. It's usually up here in the 3rd slot, or sometimes behind stroke, which is down here this year. But then this is unintentional injury again. So if we combine suicide, which is down here, and then homicide is just a little bit further down, you can see this, get a bigger picture of the magnitude of this issue. So the top 5 causes of fatal injury, you probably hear quite a bit about poisoning and overdose. That's number 1. Motor vehicle traffic crash is often what people think of as the major unintentional injury, caused by accidents and such. 4th and 5th down here are suicide by firearm and homicide by firearm. But the point I wanted to make here is that if you combine these 2, they actually zip up here into the 2nd slot. So we lose more people to firearm injury than we do to motor vehicle crashes in this country. And in fact, this is all age groups here. But if we're looking just at kids aren't affected as much from the overdoses. So the firearms are the leading cause of injury death among children. And this isn't just a COVID thing. So we've been hearing a lot more about violence and gun violence since 2020. But in fact, the increase in firearm fatalities has been going on for quite some time. And we superseded the motor vehicle crash fatality rates in about 2014, 2015, you can see here. And we haven't really narrowed that gap again. So we often talk about intent, as you've heard me talking about. And vernacularly, I've noticed all firearm injuries being clumped under the term gun violence, which is what I'm tending to do now too. Having experienced a firearm suicide in my own life, I can say it's a violent injury. But a lot of people think of gun violence as an interpersonal violence, and even traditionally in the field of injury prevention, we separated out intentional from unintentional. And there's intentional self-harm and then intentional interpersonal harm. But we tend to be grouping these all under the umbrella of gun violence, which I think gives a better picture of the impact of firearm injuries on our society as a whole. There's also some root causes for all of these things. regardless of the intent of the injury, whether it's self-inflicted or interpersonal or unintentional. Those root causes, go beyond even just access to firearms. We'll talk a little bit more about that. But this shows you like kind of the general magnitude of the suicide by firearm harm, homicide by firearm, and then we have unintentional injuries. When we're talking about deaths, this is a much smaller piece of the pie, but kind of ticks along every year. And these are your children primarily down there. And then law enforcement related injuries here. And this is just another depiction of, the rates over the years. And then how you could see how the suicide in orange, firearm suicide has increased by 27% over this 20-year period. And homicide by firearm, almost 70%. And a lot of that was in these last couple of years, but not just the last couple of years. And then another kind of distinction that we often make is like, more rural areas, more urban areas. And the patterns of firearm injuries, whether fatal or non-fatal, do tend to differ based on where you are regionally or by urbanicity, I'll say. So you can see that as you go from urban into more rural settings, we tick up in terms of unintentional injuries. We really see an increase in terms of suicide, and that kind of drives this overall number here. And the homicide injuries are higher. The interpersonal injuries are higher down there in the urban areas. So again, multiple problems to address that probably need multiple solutions and toolkits, but they're connected by these common causes as well. So depending on who I'm talking to or what we're talking about, I often like to point out those root causes and how there's commonalities in all of this, but also I may hone in sometimes on the particular risk factors or patterns for one of the problems or another. Okay, so how does Oregon compare to national? Our rates are about the same, maybe just a tiny bit higher. But in Oregon, we're losing over 600 people from firearm injury each year. This has really ticked up in the last several years. So this is about 2 people per day in Oregon that die. And when I get tagged by reporters after a mass shooting, whether locally or somewhere else, I try to remind us that every 2 days or every couple days in Oregon, we have what's the equivalent of a mass shooting, basically. So these events are terrible, but please remember that this is like a steady drumbeat of loss day after day, even in our own states. And nationally, we have almost 50,000 people who died from a firearm injury in 2021. It's really a huge number when you think about it. So we're doing a little bit better than these states in the mountainous west and along the south. And you'll see more maps of this today. But Oregon's rate of firearm injuries is about 17% higher than the rates in Washington. And we're 56% higher than the rate in California. Both of those states have pretty robust research programs addressing injury and also firearm injury. And they also have state-funded centers for gun violence prevention research. So this is one of the driving factors for me of as a public healther and a researcher, like let's create a credible source of information for our state then to create programs, interventions, policies based on numbers for our region and our culture here in Oregon. That can make us look at least more like our other West Coast neighbors. So this is the national breakdown of intent. Again, we're just looking at a pie this time rather than the blocks. And I just wanted you to see, this proportion of suicide in blue here versus homicide nationally. And then we're going to flip to Oregon. And in Oregon, we have a much higher portion of that pie comprised by suicide. So firearm suicide is a big issue here in Oregon. Affects older people in Oregon, those living in more rural areas in particular. And so, as I was mentioning before, like, different interventions have to consider these different patterns. So far, I've been talking about the fatalities, but in injury and probably in other disciplines too, we talk about the pyramid, and the fatalities that you see are only the tip of the iceberg, right? And so down underneath that, you have these injuries that result in hospitalizations, but not necessarily death. Those treated in emergency departments, other healthcare settings by paramedics only. And we haven't really had the numbers for all of these. We can get, our vital records numbers pretty consistently and with fairly good accuracy. But we're just starting to get these other numbers. So, for example, this 5-year range, across the U.S., we had over 200,000 firearm injury fatalities, almost 81,000 hospitalizations, and 95,000 firearm injury ED visits. So these are the survivors of firearm injuries. And it's almost a 1-to-1 ratio. So maybe less of a pyramid in this case because it's firearms. But still, we want to focus on these injuries as well. In fact, I think about squashing this pyramid down, so more of our fatal firearm injuries become non-fatal. And we go through these exercises thinking about this with all sources of injury. Or narrow the base of this. So we take away the firearm injury event, or we reduce the rates of those events that are causing both fatal and non-fatal injuries. This is a project that my team has been working on in Oregon to better get at that third level down in the pyramid, the firearm injuries treated in our emergency healthcare setting here. So this is a project called FASTER. It's just been refunded for another 5 years by CDC, and we're called AVERT now. And AVERT is Advancing Violence Epidemiology in Real Time, whereas FASTER was Firearm Injury Surveillance through Emergency Rooms. So we're going from firearm injury only to multiple violence syndromes, as they call them in this program. But this is a snapshot from a dashboard that we've created, and we'll be updating quarterly. And we're delayed with this end of year update here because we are going through the IRB modification, going from FASTER to AVERT. So this should be here soon. I'm anxious to see if we're continuing a downward trend here, or if we'll pop back up in the 800s again. But what you're seeing is the total number of firearm injury related visits to emergency departments across the state. They feed their data in through Essence, which is a syndromic surveillance system, and it feeds into our state health department. The Injury and Violence Prevention Group there commissions us to take the data, work with the data, and translate and present the data. So it's been 3 years we've been doing this, and we're getting a little bit better. And I think little by little, we're getting better at all of this, but it's been a massive undertaking. And this shows you those ED visit rates across Oregon, or by county across Oregon. So you can see, the population is driving this. These are just the numbers. So we go up and down the I-5 corridor, of course. We often see Umatilla County popping over here. When we look at rates, you see a bit of a different picture with some of those more rural counties popping out. So I often also like to share with people that firearm injury and gun violence is not just a Portland thing. We do really feel it up there. We've really been feeling it for the past couple of years, but it is in fact an Oregon thing, and is affecting people from all across our state. Okay, so I know I don't need to go into great detail here, but just like everything else that we do in public health, we want to define the problem, identify risk and protective factors, figure out what works, and then expand what works, right? As simple as that. But we're so behind in the study of firearm injuries and gun violence that we're working on all of this now. We're playing catch up, and we're getting a ton done here and across the country by my colleagues. But still so much to do. So we're working on all 4 of these boxes. simultaneously. I'll share a little bit of that today. But all of this is because we know that you can reduce rates of injury. So what we consider accidents or acts of God or, unpreventable are indeed preventable. And we've seen this with those rates of motor vehicle crashes that have gone down over the decades. And that takes resources and it takes science, it takes translation, it takes advocacy, it takes money, takes organizations at the national level, which motor vehicles have, but firearm injury has not had. It takes engineering. And there's a lot that we can do engineering-wise to make something like a firearm safer as well. So all of this that's gone into the efforts, it's a 30, 40, 50-year effort that's gotten us to a lower rate of motor vehicle crash fatality. This is the long game, and it is incremental gains that we're feeling, but we will get there too with firearm injuries. We just have a lot of work to do. This is rates of fatal motor vehicle crashes you can see over the last century that have come down this much, even though we have more drivers, more cars on the road. So the same absolute number of deaths, but the rates have really decreased. So reframing this is really important. First of all, we're not fighting over gun control versus gun rights, right? That is ridiculous. Cars are here to stay, so are firearms. There is all sorts of stuff that we can do in the middle, together with firearm owners, Second Amendment advocates, people like my family that just live with firearms for utilitarian reasons. But if we all have the same end goal in mind, then there's so much that we can connect on and that we can get done. And that's addressing those different views and values on firearm ownership and just acknowledging other people's views and values and finding that common ground, safety and harm reduction. And then coalition building is going to be really, really important in this area, I think, for all of those reasons. These partnerships, this is just, a drop in the bucket in terms of all the partners that are needed to make this happen. But these are the ones that come to mind most quickly for gun violence reduction, healthcare, law enforcement, so faith community, us here in research institutions, community-based organizations, policymakers. It's a lot of work to be in communication with everyone that we need to. But I think it takes all of us to get this done. And of course, all of these diverse perspectives, but holding that common goal in mind. Okay, so I truly believe culture change is possible. We've all witnessed it. Of course, it may take a generation or two, but it's possible. Possible with safety too, right? And in my youth, we were fighting against seatbelts. And now it feels like you're naked if you don't have a seatbelt on, right? So things can change when multiple factors come together and drive that change. And finally, the mantra of any injury preventionist is that injuries are not accidents. So we try everything we can do to not say the word accident. But because they're patterns, they're predictable. And because they're predictable, they're preventable. And this is the core tenet of everything we do. And to extend that to violence, we can also say that violence can be a normative and adaptive human response to what are abnormal and maladaptive structures and systems, right? So I haven't spent much time in this presentation talking about health equity, but that underlies so much of what we do in firearm injury prevention as well. So I love this saying because it points to the upstream social determinants, and also, intervenable factors in our systems that can reduce violence when otherwise we feel like there's so little that can be done sometimes. So more on social determinants, I think one thing that I spend a lot of time thinking about is this one right here, economic stability. This affects our rural areas as well as the portions of our city that are really impacted by gun violence. And all of these pieces are important. We find that built environment in neighborhoods, your environment is actually a strong driver of your exposure to gun violence and the rates of gun violence. So all of these really important. This is a chart just to depict what I was just saying about geography. This is the city of Portland boundaries. These are neighborhoods in Portland that are colored in according to the social deprivation index. The darker blue are the parts of Portland with lower or with higher social deprivation, so lower resources in these areas. The dots overlaying them are events of interpersonal firearm violence, whether fatal or non-fatal. And you can really see how these cluster in the dark blue areas and in downtown Portland, which is also dark blue. They also tend to cluster along our major roadways, which points to the need for pulling in planning, design partners, transportation partners in this issue. We're also trying to do this with the state of Oregon. This is a lot harder to do because for privacy purposes, we can't use dots with the data we get from the state, but we kind of have a two-dimensional scale of firearm injury rates here and social deprivation here. So if you look for the darker purple colors is where you're seeing the overlay or the strong correlation between social deprivation in regions across our state and firearm injury rates. So to me, the section in Mount Hero County pops, Umatilla County continues to pop down here in the southern areas, and then Jefferson County too. And you can say, when you see maps like this, you can, and you know the state, you know, or your community, your city, things stand out to you, you know, like, oh, what's going on in Umatilla County? But if you know the history or you're familiar with the area, then it helps you identify things that our numbers may not otherwise identify. So the social ecological model we use quite often in this to drive our design, like the design of our work, but also our communication of the work. Because it is all four levels: individual, our family and social relationships, our communities, and then societal as a whole that impacts our exposure to gun violence. And really, we tend to hear, you know, the blame at that individual level. But as we drive outward, as we all know in public health, the more impact that we can have with the changes that we can make. So I'll share a little bit of what we're doing at this center. This Center for Gun Violence Prevention Research is just what I've coined the center. I put a grant in 2021. The end of 2021, we were already doing some of this work, and there was this internal foundation-funded grant for faculty that I applied for, and I shared my vision of having a research center, why we need a research center for the state of Oregon. And we got this funding, which lasted for 3 years. We're in our final year now, so I need to find the next big funder. But this funding allowed me to kind of say, like, hey, we're a center now, and I'm hiring all these people, and we can finally do more. All these things that we get asked to do, and some of the unfunded research projects that we'd started to do with students and all of this. So it really has like fueled what we were able to do. Let's see. So the focus of the center mainly is, you know, as an epidemiologist, I love the numbers. I want reliable, valid numbers, which is a challenge in and of itself, a full-time job in and of itself. But we're trying to do this. Fill in these numbers, you know, at each of these levels for our region and state. Also, examining the causes and consequences of firearm injuries, again, looking through the social ecological lens. And then we're doing some work on the effectiveness of intervention, so more evaluation work. So our state passed an IRPO law, which I'll share a little bit about in a bit. That's what some may have heard called a red flag law, extreme risk protection order. is what ERPO stands for. HVIPs are hospital violence intervention programs, and we have those going on in our level 1 trauma centers in Portland. But last year's legislative session resulted in funding to expand those HVIPs to other hospitals outside of the Portland metro area across the state. So we should be seeing more of that in the years to come. And then, of course, ultimately dissemination of data to advocates and policymakers. And I find us doing this quite a bit of the time. And as an epidemiologist, I'm more comfortable behind the screen working numbers or writing up describing numbers, but we're getting better at figuring out fact sheets, one-pagers, the maps to depict what we're trying to say, like these shorter things that we can share with, a policymaker as well as a community member, the dashboard, for example. So learning a ton of things as we go about this work. And it's really been a growing body of work. This down here was the first time I threw my hat in the ring with a firearm injury related project. That was after Sandy Hook. And after I lost my grandpa, I thought, I'm an injury epidemiologist. Why am I not studying this issue? And so President Obama declared after Sandy Hook that the NIH and the CDC will start funding gun violence related research again. And so they had an RFA out, and I got a little baby grant, an R21 for that work. But that got me going in this realm, and all sorts of things happened after that. 2020 is when we started a VA-funded project to build a program of firearm injury prevention, a healthcare-based firearm injury prevention program in VA healthcare settings that went beyond just firearm suicide prevention, which the VA was already pushing the boundaries with, but more comprehensively, let's keep you and your firearms living safely together. And how can we do that from within a healthcare setting without making lots of people mad? That's what we've been working on. The FASTER project, as I mentioned, other projects, I'll talk more about the VA project and our ERPO evaluation. And this just keeps going, like mushrooming, is what I intended with that visual there. But also I have to put a slug in here too, because it feels so slow. And just lots of work to do. And when the data systems haven't been used or established before, for the enumeration of what we're after, we have to do a lot of groundwork just to validate what it is that we're trying to understand. So a lot of foundational work, which feels very slow, but I think we're getting there. So we're growing a big team. This foundation grant that I got to start a center has helped with this. And then also building these relationships with our public health practice partners in the Portland region and also around the state, which is fun and exciting. Community partners too. We spend quite a bit of time meeting with community partners and learning how to produce data that is most helpful and meaningful to them, which has been another big learning curve for us, I'd say. Okay, 5 more minutes, maybe. I'm going to go a little bit quicker here, so we have a little bit of time afterward. And this is an evaluation that a medical student approached me about doing a project. She had to complete a research project for her program. And so she started this project, and it was unfunded. And then we've been able to pull in this team of people here, some students, but also some funded RAs to help us code every single ERPO petition that was filed through the judicial system in the state of Oregon. And so far, we've analyzed 2018, which is when the law began, through 2022. So we have 5 years that we're reporting on, and now working on 2023. So a big part of reducing all sorts of firearm injuries, unintentional self-harm and interpersonal, is managing access to lethal means, or in other words, reducing access for people who are at high risk or at risk even. And these ERPOs, extreme risk protection orders, are just one tool in what should be a full toolkit of all sorts of things, because we need lots of options for all of the different scenarios that people get hurt in, or that people need firearms for, or interacting with firearms. And so ERPO is just one, but it's a really important one, and it's taking off across the country. After the Marjory Stone Douglas shooting, school shooting in Florida, this is when they really blocked them in popularity. And as of January of this year, we now have 21 states and DC that have enacted ERPO laws. And basically, they allow certain individuals, so specified individuals, to petition a civil court, not a criminal court, so it's a health issue, civil court, for an order to temporarily restrict a person's access to firearms or other deadly weapons if the court determines that the person is at imminent risk of harming themselves or others. So you'll hear sometimes after some of the mass shootings, and the Parkland shooting in Florida was one of them, that there were red flags. There were signals that this person intended to harm a bunch of people. And a tool like this could have been used, if available, to stop that person. So in Oregon, we passed a law in 2017. It was enacted in 2018. And in our state, family or household members or law enforcement officers are allowed to be petitioners. And they must meet a burden of proof requiring clear and convincing evidence for a petition to be approved. And the order, if accepted, typically extends for 1 year, unless there's a successful request to terminate earlier or a renewal is granted. So we've looked at this first 5 years of ERPO petitions. Move forward quickly. And you can see that in these first 5 years, we've really grown in the number of petitions that were submitted. The number that are approved has stayed about the same, about 3/4 or 80% or so are granted. And these are being used all across the state, but we have 6 counties that haven't yet had any ERPO usage. These are not depicted here. We're restricting any counties with less than 5 petitions from this map. But you can see that these Central Oregon counties are high users of ERPO. And some of these counties, I think, that are aware of high suicide rates, and what we're learning tend to have champions of this law that are leading to it being used more often in those areas. Most petitioners are law enforcement officers. That's this piece of the pie here, and then family or household members over here. And those petitions filed by law enforcement officers are the most likely to be approved. That's probably because of their familiarity with the law and the courts and so on. These are the threats cited in the ERPO petition that we extracted. So assault, self-harm, both assault and self-harm are these big ones here. Domestic violence in about 35% of the records, harm to children, and then mass violence and threats to school are not uncommon. They're the least common of this grouping, but they are the most likely to be approved, interestingly, to be granted versus denied. So of the 506 petitions that were granted, the respondent requested a hearing. So through due process, they can have their hearing. It can be attended by a lawyer as well as the respondent. And in 22% of those cases, they did request a hearing, and that was held. And in about half of those, 44%, those ERPOs were dismissed. So this is suggestive of due process being carried out in the court system in Oregon, which we've had discussions about this law with our Second Amendment advocates who have concern about the possibility of not enough due process being followed. And we think this suggests that this is occurring in a relatively large proportion of cases. Alcohol use and abuse is cited in about a fourth of these records. About a third cite domestic violence. And then there's this large proportion that are filed by ex-spouses and ex-intimate partners. And if they are not currently living, married to, they're not family, if they're not living with the individual, they don't have standing to submit a petition. So a lot of these end up being dismissed due to lack of standing. But there are, in reading through these scenarios, there are fears among ex-spouses and ex-intimate partners, oftentimes that involve their own safety or the safety of shared children, but maybe also the safety of the respondent as well. These are some vignettes I like to share. Maybe just read the bolded terms here for lack of time, but I like to share the vignettes just so that you can get a feeling of how serious the issues are when someone gets to the point of submitting an ERBO petition. To me, it's also breathtaking that this is going on around us all the time, that people are experiencing these traumatic events, and that it's nice that there is a tool available to help them in these situations. Okay, so ERBO is being used. It's growing year by year, but moving forward, we think that there's some gaps in implementation that we're trying to understand and address, especially in the counties that are using it quite effectively and counties that aren't using ERBO at all. And so the health authority is just offered to fund us to conduct a series of qualitative interviews with professionals that are involved in the ERBO process across the state over the summer. So we're anxious to learn more about, boots on the ground, what's going on when ERBO petitions are drawn up, submitted, what are the barriers, what are the facilitators, how can we make sure the tool is useful for those who are in need. Okay, so I'll skip over the VA rural health program and the veterans piece for the most part. Mainly, my point is that veterans are at increased risk of fatal injury, and as part of that, they're at increased risk of fatal firearm injury. Veterans have higher suicide rates than non-veterans, and a higher portion of veteran suicides are completed with a firearm versus other lethal means. So we know there's a higher rate of firearm ownership among veterans. There's training in how to use firearms. So presumably greater access to firearms, and this leads to greater rates of firearm suicide in this population. So my interest is how can we within a healthcare setting address injury risk, particularly firearm injury risk, in a way that's effective and in a way that's matter of fact and not stigmatize people, but engage people instead. And so we've been working on this for 4 years now in a couple VAs in rural areas of the U.S. I'll show a map here. So these are where, this is kind of like a bowl of spaghetti almost, but these are the hot spots of firearm injuries or firearm fatalities among veterans across the U.S. And when we do hot or cold spot analysis, you see this region across the mountainous west and then the south really light up. So we're working here in a small VA facility in Louisiana, in rural Louisiana. And we just started working with a VA medical center in Wyoming to test out and to develop and test out what this toolkit and program of firearm injury prevention can look like. Part of this project, one of the tools in our toolkit, is collecting stories of veterans themselves. In this work, as well as our work in interpersonal firearm injury, gun violence in more urban areas, there's a real disconnect between us as the researchers and public health practitioners and the people that we're trying to prevent injury in, right? So we're constantly thinking of this. How can we close this gap? How can we work with people who are the credible messengers for those who are most at risk? And in this case, we decided to use a methodology called DIPEX, or Database of Individual Patient Experiences, where you capture people's stories about some kind of injury or illness. And in this case, we found veterans that had been injured by a firearm and survived their injury all across the U.S. and asked them what happened. So we listened to their story. This guy's local, if you can't tell.
So I did fresh for it on my wife. And started cleaning it up so I could sit there and watch TV with her and the kids. And I had gotten through, I think it was 4 or 5 firearms that I had taken. And my oldest daughter had taken them back to the gun safe and locked them up for me. And the one firearm that I left out was a 5-shot snub-nose 38 special revolver that my wife at the time often carried in her purse. She had still carry license if she was going out to the store or after dark or anything else like that. And as such, I had reloaded it. So that I could put that in the bedroom up where the kids couldn't get it and she could reach it later. And I happened to glance down on it and noticed an oily thumbprint on a highly polished, beautiful, flawless 5-shot cylinder and said, we can't have that oily print. So I reached down and I picked up the pistol with all new safety in mind. I guess I should have had a pistol here. And my finger was not on the trigger. It was a double action revolver. It was not cocked. And I wiped the hammer with a rag, or not the hammer, I wiped the cylinder with a rag, and somehow it snagged on the hammer. I don't even remember exactly how it happened. Pulled the hammer partway back and then released it. Well, my hand was right here. And it blew a hole. You can see the scar right here, and especially right here. It blew a hole through my hand on the backside. You could have dropped the silver dollar in it, and I was looking right through my hand instantly. And I looked over at my wife, kind of surprised, and she looked at me, kind of surprised. She goes, "What the hell did you just do?" I said, "Give me a towel." And she said, "It's funny now in hindsight." And she said, "You put your finger wasn't on the trigger." And I said,
I like him because, as a credible messenger, like this is a veteran that can bridge divides between, a firearm lover clearly and a hobbyist, and then physicians or healthcare providers that may not be as familiar with firearms, but this is your gregarious, lovable veteran that can tell you, like, here's how it is. And also, by the way, I got injured and here's how it happened. We also use these stories to kind of break down that stigma of negligence, because that is pervasive in the firearm community, that there's so much personal responsibility, which is true. But in public health, we're trying to go up to the societal level, right? Or upstream and we know that humans will err and get injured. So we're trying to use these stories to kind of break down that stigma and move away from that negligence as such a negative thing. And having veterans be the messengers of that. So I have another veteran that I'll skip over, but he shows his hand and he's actually missing an entire finger on his hand. And these are unintentional injuries, which is also what I want to raise awareness about, because they're so much more frequent in the groupings of non-fatal firearm injuries, but we often don't talk about them. Okay. So in conclusion, just some of the takeaways I think from the whole gestalt of all of it is that data are fundamental, but so is translation. And I would say over time, I didn't share much of the qualitative data with you today, like collecting stories, using mixed methods in addition to the epidemiological approach, and developing better data and better data sources. It's all so important, as is that translation piece. So much to do. Public health is not well understood. So as we've all experienced in the last several years, we have a lot of explaining to do. And then the partnerships and connections, meeting people where they are, considering and maybe sharing your own positionality, and elevating the voices that have experiences really stood out as a way that we can close some gaps improve our communication, be more kind of show humility, and hopefully in that way be able to move forward in what's otherwise a highly tense topic. And that's it. Thank you. Thank you. Just my acknowledgements, and then landing here on, I know I wasn't using entirely trauma-informed language today, and I like to acknowledge that it is, really hard and heavy topic to sit with and to hear about. So we do have resources if anyone's feeling crummy, and these are great resources.
Right. Thank you for that talk. That was really interesting. So Dr. Carlson has agreed to stay after and discuss further with folks in the room who are able to stay. So maybe let's start with questions online. Okay.
I was wondering, for a long time, it was illegal for the federal government to fund research on gun injuries and such. Has that changed, and how did it change?
It has changed. So there's debate about the illegality of what happened, but basically there was a threat that the CDC's budget for their entire injury center would be wiped out if they continued to conduct research that would promote gun control. So that just hushed everything that everyone was doing. There were also death threats among my mentors who were doing this kind of work, or just shut it down. And I often reflect that even when I was writing that first NIH grant, I was really worried about my own safety and safety of my family. And we would speak in whispers about it. That was what I was raised up with, the understanding that you just didn't touch firearm injury. What changed is first Sandy Hook and Obama saying, we will fund this. So that was an RFA that was out for 4 or 5 years. It's been removed and replaced now with a federal funding bill that has given $50 million to split in two. So $25 million to the CDC and $25 million to the NIH, which is a drop in the bucket when you think about multi-year grants to study enormous public health burdens, but it's something. We also have private foundations that pooled money together. And then we have state organizations that have been funding work as well. So the California State Firearm Injury Prevention Center. So we're cobbling together money from all sorts of different sources that I could also apply to NIH. And we do get CDC money through our state health departments. And then the VA was really progressive about funding this work too. I was a little bit cautious about approaching that at first also. That was just 2019 when I was talking about getting VA funding, and they were all in for it. And that was because of the effect of firearm suicide on our veteran population. So I think the horse is out of the barn now and we can't go back, knock on wood. I think, with every mass shooting, sadly, we get closer to that tipping point of we need to invest in this. I don't know when we'll get to that finally, but it has been changing even over my, last 5 or 10 years of public health work.
Good question. Okay, still no questions online. Other questions? Yeah. I wonder what's HERPO is it just restricts or access to firearms, or do they offer anything to try to rehabilitate?
Yeah, that's exactly what we want to ask with our interviews this summer, is what goes on. There's some evidence in the petitions themselves, but that's not the point of the petition. Sometimes you can detect, though, that this person was put on an involuntary hold or checked themselves in to some program. But really, ideally, you would have a warm handoff for this person to get the help that they need, right? And I think there's some evidence of that going on in Washington. And hopefully we'll find that here in Oregon too. And then that's what we can build toward in improving the use of HERPO as it is intended, right?
follow-up critical question. Is there any movement at the state level to expand that legislation to allow school like
Yeah. So there is effort to expand who is eligible to petition. I can't tell you for sure if ex-intimate partners are included in that because there are domestic violence restraining orders. There are other restraining orders that are intended specifically to help that group. And they're more comprehensive than just the firearm removal piece. So to be determined, but yes, there is talk about some states allow educators to petition. Some states allow healthcare providers to petition. And then ultimately it comes down to the judge. So we see evidence in some of the petitions here that someone without standing, like a healthcare provider, sometimes petitions. And even though they don't have standing, the judge occasionally approves that.
Well written. Okay, other questions from the room? Yeah, Dr. McLovin.
Yeah, thank you for your presentation. There was a disconnect right at the beginning for me in terms of you showed an early map of the United States where sort of the pattern that exists of, I guess, number of violence or number of injuries or number of deaths, I can't recall, but it looked remarkably similar to a map of the United States. It might look like smoking, diabetes,
right,
obesity.
Yes.
And then you said just a little bit after that, something to the effect of, guns are here to stay. Mm-hmm. And I'm wondering if in that map, you actually looked at number of guns per household, mm-hmm. And factored that in and how similar that would be. Because I would like to believe that reduction of guns is a good thing that could occur in our country. And so that sort of stuck with me about guns are here to stay. And then later in your talk, you showed sort of the increase in the number of cars and the decrease of the number, which is remarkable if we could make guns safer.
Yeah,
but we probably can't. And so it's you know what I mean? Sort of with that
airbags for guns.
Well, there you go.
There are ways to make them safer. So it's a different engineering feat than for motor vehicles, but there has been controversy about modifying, using electronics with firearms to control them, and the fear that you need a firearm when you need it and then you can't get it to work, just like your cell phone when you can't get it to work or whatnot. But we don't have good measures. I mean, historically, our foundation is that, you have firearms as a source of protection. And there's very little data available on how many firearms out there are. We basically model it using inputs like proportion of suicide deaths that are from firearms, number of new gun sales, things like that. So that it's all estimates. But of course, those lit up states are going to be the ones that have the higher ownership of firearms. They just tend to be. But I don't know. I mean, having grown up in a households with firearms, I just feel like everybody has firearms, but maybe they don't. But I don't know. I just feel like it's pervasive and it's everywhere. And I don't mean to say that firearms are here to stay, because I do try to paint that long-term picture. And maybe we do get to that point. Like other countries have gotten to this point where they make a big change. I don't see it in the near future, and I'm here to do public health right now. So that's basically what I'm saying is they're here to stay for now. Let's do what we can do.
Thank you, Dr. Cross.
Thank you. I don't hear